behalf of SAJIDA Foundation, I'm Shamira Mustafa. I welcome you all, and it is a pleasure to welcome you all in this important COVID-19 webinar. As we all know, over the past 3 years, our world has gone through unprecedented challenges. The COVID-19 pandemic cast a dark shadow affecting nations worldwide. While it may appear that the pandemic has subsided, the road to recovery remains distinct, particularly for low and middle-income countries. COVID-19 has left enduring impacts on physical and mental health, healthcare systems, economies, and much more. However, amidst the trials, we have witnessed moments of hope and the spirit of community. Individuals and organizations have united, offering support and devising innovative solutions to combat the pandemic. Healthcare professionals, scientists, governments, and NGOs have worked tirelessly, propelling us towards the light at the end of the tunnel. SAJIDA Foundation stands among those remarkable organizations that have dedicated themselves to the COVID-19 response since its inception, employing various interventions and conducting crucial research. Today, we are delighted to assemble experts from diverse institutions and countries to share their invaluable experiences and insights on the multidimensional impacts of the pandemic on low and middle income countries. We anticipate a fruitful discussion that explores the challenges faced, the successes achieved, and the lessons learned throughout the pandemic. Moreover, we aim to explore ways to empower LMICs to confront future unprecedented events such as pandemics. Before we commence, I would like to express my special gratitude to Dr. Zarina Nahar Kabir and Dr. Ahmed Mushtaq Raza Chaudhry for graciously chairing today's sessions. Their expertise and guidance will undoubtedly enrich our discussions. With great anticipation, I now give the floor to Dr. Zarina to preside over the first plenary session of today's webinar. Thank you, and I look forward to an enlightening and thought-provoking discussion. Over to you, Dr. Zarina.
Thank you, Shamira. And a very good afternoon to you all, or good morning, depending on where you are around the globe. For example, in my case, here in Sweden. I'm Zarina Nahar Kabir and an associate professor of public health at Karolinska Institute in Stockholm. My research focus, among other topics, is on aging, family caregiving, digital health, specifically mobile health, or what is known as mHealth. Over the past couple of years, I've had the opportunity to work with SAJIDA Foundation on research related to the COVID-19 pandemic. I think SAJIDA Foundation is a rare example of a humanitarian organization in Bangladesh, which launched a systematic collection and documentation of evidence by initiating an epidemiologic research as the pandemic unfolded. Today's webinar is a part of that effort to share experiences and lessons learned from the pandemic. The webinar will be divided into 2 sessions. The first session will include 4 presentations on the challenges of COVID-19 in low and middle income countries from the perspectives of different stakeholders. The session will also focus on the consequences of COVID-19 on mental and physical health. The second session will include 2 presentations, which will focus on lessons learned and response to the COVID-19 pandemic in LMICs. So I hope that by the end of today's webinar, we will have a better understanding of how research evidence on the pandemic can guide response to future emergencies, not only by governments, but also by humanitarian organizations, and specifically in responding to crisis never encountered previously. Before I introduce our speakers, I would like to cover a few housekeeping issues. Today's webinar is being recorded. We will be able to share a link with you at the end of the event. We welcome you to revisit the content yourself and do share it with your colleagues. We are hosting the webinar on Zoom and also broadcasting on various social media such as Facebook and LinkedIn. We invite your comments and questions. For those who are joining us through social media, please post your questions or comments in the comment box. Those of you who are here on Zoom, please do post your questions or comments in the chat box on your screen. You can just type in your questions at any point. Each presentation will be immediately followed by a 5 minutes Q&A session. Also, apart from the presenters, I request you to please keep your microphone on mute. And with these housekeeping issues out of the way, let's get started with the presentations. It's my pleasure to introduce our first speaker, Mr. Ahmed Jojon Nandonik. Mr. Nandonik works at SAJIDA Foundation in the Department of Research, Monitoring and Evaluation. He has a degree in economics and is currently pursuing a master's in development studies. He's been working on several research projects on COVID-19 since its onset in Bangladesh. Mr. Nandonik will talk about the experiences of different stakeholders in relation to COVID-19. Over to you, Jojon.
Thank you, Dr. Zarina. Moving directly on to the presentation. So here's a bit of a background. COVID pandemic has been an important event for lower middle income countries' health system, and with existing challenges and health resource scarcity, a pandemic like this showed that it can stretch out the overall ability of the system. And for Bangladesh, it was no exception to that. Also, we have seen multi-dimensional impact of COVID in Bangladesh, which includes not only health, but also other domains like financial and social aspects were also affected. And considering that Bangladesh has seen emergence of new poor, also there is impact of post-COVID physical and mental health consequences. Now, to tackle a pandemic like this in future, there should be a very concrete and effective response strategy, which includes the experience of people which were somewhat missing in the current Bangladesh response plan created by the government. So the focus of this session is to present the experience and perspective of three different groups. And so the first of the three different groups are healthcare professionals who served COVID patients in critical times. And second one is family member turned into a primary caregiver of a COVID patient. And their experience will allow us to know how families think collectively. And lastly, it's about patients' recovery journey and uh, changes that occurred in their life after coming back from the hospital after the initial recovery. Um, all the studies were descriptive qualitative studies. Uh, one of the categories of the respondents were family member who took care of a confirmed or suspected COVID patients living in the same house. And we considered both suspected at COVID cases because at the early stage of COVID, the testing facilities that are available right now were actually not available back then. We also interviewed people who were hospitalized after being diagnosed with COVID and went home after the initial recovery. And for healthcare workers, we interviewed physicians, nurses, and formal caregivers. Sources of this sample were Sajida Hospital at Naranganj, Sajida Health Information Hotline call list, and employees of Home and Community Care Limited, a social enterprise of SAJIDA Foundation, which provides healthcare services at the comfort of patients' home. We had to opt for online interview to address the physical distancing protocol, and these studies were conducted separately using either thematic or content analysis. So here you can see a table, uh, themes on the left column, and three different perspectives of three different groups will appear in each column, and I'll highlight some of the points. So starting with the healthcare professionals' perspective, if you look at the challenges, we tried to explore their challenges at both personal and professional level. And at personal level, while working at the hospital, they had to stay in a separate place after finishing their shift, and long distance from family was not easy for them to accept. And also, on the other hand, family members of those professionals were also in stress knowing that their loved ones are working at the front line. So, and one of the doctors who haven't been able to see her families for months quoted that they felt their life remained in lockdown even when others were with their families. One of the major challenges at professional level was changes in treatment related information. A doctor providing health services through hotline mentioned that they felt like they are working in the dark as it was a completely new experience for them. Having said that, the motivation that kept them to overcome the work-related stress and personal challenges and kept them going were a sense of responsibilities and appreciation from the patients themselves. And organizational support or cooperation from hospital authority they received, be it with providing protective equipment or managing a place for them to stay, gave them some sort of sense of security, which eventually played a key role to motivate them in carrying their services forward. And speaking of family caregivers of patients at home, they faced challenges both logistically and socially in maintaining the physical distance, as housing in urban areas are expensive and typically crowded, and these space constraints made it difficult for families to maintain the recommended safety measures. With many difficulties and challenges, some unexpected positive outcomes were also the lockdown as somewhat blessing in disguise for families to strengthen their relationship as they had enough time to spend together, which was not possible in pre-COVID period. And besides that, the overall hygiene habit improved by practicing COVID hygiene protocol over and over again. And an interesting finding of the study with discharged patients was that uh, urgency of going back to work or working extra hours to recover the financial loss incurred during lockdown made it difficult to prolong their physical rehabilitation period, and which, uh, according to them, affected them both physically and mentally. And many of those who suffered from COVID described it as a life-changing experience and an opportunity for self-discovery, appreciating life. So based on the findings, following are the main highlights. One, there was a lack of unified platform, which could have been very handy for the frontline health workers or the uh, professionals of serving during pandemic to access information and not turn into unstructured internet browsing and land onto false information which could potentially mislead appropriate medical practice. Second point highlights the interplay between social, financial, and health domains, as the restriction on mobility was lifted by the government. One of the major concerns for people was to recover the financial loss by returning to work as soon as possible, which resulted in physical issues like heaviness on chest while working, lack of sleep, uh, memory loss, and etc. So these physical health related struggle interplay with financial struggle resulted in psychological distress. And such interplay should be considered in mitigation plan for future similar pandemic. And lastly, we observed that uh, informal family caregiving remained the main source of support during pandemic in Bangladesh. And we found that the initial support for patients with COVID-19 came from the immediate family members, and it also continued throughout the recovery period. So it is important for state to include families in rehabilitation process, and especially in a resource poor country like Bangladesh where the formal support is limited. So this was all about my presentation. Thank you so much for your patience.
Thank you so much, Jojun, for your presentation. I see that questions are coming in. Thank you, audience, for your questions. Keep them coming. Meanwhile, Jojun, there's one question which says, did you explore if lockdown is not the right measure for LMICs? What can be practical yet effective to restrict the spread of an infectious virus like corona? Jojun?
Well, lockdown measures can be effective ways to slow down the spread, but however, it has significant social and economic impact, especially for those who are marginalized. So,
But yeah,
if I had to suggest that yes, lockdown is an effective measure, but it has to have some systemic way of imposing it. So, in future, um, there should be a guideline and systemic way of imposing those lockdowns, and also government has to ensure some financial security or having a safety net or allocate a fund for that as a preparedness for pandemics, which for which people, a vulnerable population, can lean onto and uh, do not have to desperately go out and accepting the risk in search of livelihood.
thank you. There is another question here. Did you explore how each group coped with the challenges faced? And if so, how?
Well, yes, uh, I mentioned in my presentation that, for example, for healthcare professionals, the flow of new information was a challenge. And although there was national and WHO guidelines, which they mainly followed, but there were some context-specific challenges, and for these, they had to rely on shared knowledge and continuously exchanging their ideas among themselves, among the professionals, as it was a new experience for everyone, right? So uh, through this discussion, which it helped them to keep track of the treatment related information and implementing that within their practices, and also listening to their supervisors who are experienced in somewhat experienced in managing patients. And also the assurance from the hospitals uh, helped them to cope mentally, because it was a stressful situation. And if we uh, talk about patients, yes, it was a stressful situation for them as well, but uh, some explored this as a positive experience for them and used it as a personal growth, devoting themselves spiritually and acknowledging what they have.
Mm,
So yeah, so these were the main coping strategy for them to cope up with physically and mental challenges.
right. There's another question about whether you came across anyone with long COVID, and if yes, how were they cared for and by whom?
Well, yes, um, there have been cases of long-term consequences which affected them both physically and mentally. And uh, initially, government were mostly focusing on curbing the spread of COVID, which is understandable, but there is long-term consequences, and uh, the voices of long haulers are not yet amplified, and there is no specific guidelines for them yet how they can cope up uh, with their existing physical and mental health challenges, which are the consequences of COVID. So, so the,
Right.
what we have seen that these were mostly they were maintaining them personally and going to healthcare professionals, but there is no certain guideline which they had with them and which they can follow. So here as well, the informal care was also the main source of support for them.
Let's take a last question to answer your questions. Did anyone
Well,
refuse to
uh,
be
well,
interviewed?
in we conducted the qualitative study, and uh, there was not there wasn't any sensitive questions there, and we received a positive response for them, and no, we haven't really faced any kind of refusal. But yes, when we reach out to a pool of respondents, some didn't wanted uh, to participate, but those who participated haven't uh, haven't refused to answer any of the questions that we have.
Sorry, one final question also. Was there any difference in results between socioeconomically better off and other groups?
Well, yes. So those who were are better off, and particularly those who were admitted at the hospital, they had somewhat an advantage to further health related checkup and uh, take a bit of a rest so that because they were financially well off, and those who didn't, uh, they had to make some tough and unwanted decisions like cutting down to expense. Even a few said that they weren't been able to go to healthcare professionals and haven't been able to afford the recommended test that they were given. So also uh, many of them had to shift their home to a more affordable places because of the loss they had incurred during the lockdown. So yes, there was some differences between the well off and the one who were not financially well off.
Right.
I hope I
Mhm.
was able to answer your question.
Thank you so much, Georgia. And just on the point of lockdown, just want to share that I'm based in Sweden, and Sweden was one of the rare countries which did not impose a lockdown. It was criticized quite a lot at the beginning of the pandemic. The reason for not imposing lockdown, one was a constitutional reason. The constitution doesn't allow the government to impose such a lockdown, but also our public health agency had the approach that uh, we needed a long-term change in lifestyle and not an immediate restriction on habits, because introduction of a lockdown and then lifting it may actually could have brought us back to our sort of old habits of crowding and hygiene practices and so on. um, Evidence from about a few weeks ago shows that in terms of negative outcomes of the pandemic in Europe, um, Sweden had the least negative outcomes. if you look at it long term. So it did make sense eventually to not have a lockdown, but introduce a slow process of lifestyle changes, public health behavior, and so on. Okay, let's move on to the next speaker, and thank you, Mr. Nandonik. It's my privilege to introduce the next speaker, Professor Megan Mutepwa, who is based at the Department of Psychology, Faculty of Social Sciences at the University of Botswana. Professor Mutepwa teaches psychology and public health courses, including communicable diseases. She's a registered psychologist with more than 10 years of cross-disciplinary experience in psychotherapy support services and worked as a research consultant for the Pacific Institute of Research and Evaluation. Her main research interests are health and well-being, HIV and AIDS, abuse, aging, and COVID-19. Her current research is on personal and family coping with COVID-19 in the Global South. She's also co-founder and director of a charitable organization accredited to the United Nations named Ageless Inspirations Botswana. She will talk about multidimensional impact of COVID-19 in Botswana. Please, Professor Mutepwa.
Okay, thank you. Morning, everyone. I've just tried to share. My slides available?
Tahmina, do you have Professor Mutepwa's slides?
We're presenting it right now.
No, we are just seeing save as. We are not seeing the slides.
Okay.
So we are seeing a dialog box.
Professor Megan, can you please stop sharing your screen?
Yes, now we actually did get it for a bit.
And then they closed. Let me type in and
Yes.
they are there now.
Now it's showing Professor Mutepwa. We have your slides.
Okay. Yeah. So we did a research on COVID-19 and we looked at so many variables. Initially, I wanted to do a meta analysis of the studies done in Botswana, but I realized that most of them were not yet published. So I just decided to go with research that we did on COVID-19. This was done by a consortium of 12 countries in the Global South, and Botswana was one of them. So Botswana has been impacted, I won't say severely, because apparently we are in the top 10 of those who managed the COVID-19 well. So I'll just give the impact on a global impact, then I'll go on to the impact on Botswana, so that we understand where we're coming from. So if you look at these slides, the global economy declined by 3%, which was worse than the decline due to global financial crisis. And also international trade projection was 11%, with exports hardest hit due to restricted export and movement. And this did not apply to a few countries. There are so many. If you can see the first world countries, there was a decline of 7, USA 6, and developing countries 1%, with growth in China and India. This is by IMF. Then Botswana implemented measures after 23 cases, which was quite early enough. Maybe that's why we didn't have a surge in numbers. And we only had one. Then after that, Botswana imposed a lockdown. Although it reduced casualties, it had economic repercussions. And the challenges included the prevention and management of chronic disease after the COVID-19 infections, because we were not prepared. Our hospitals were also full when it was at its peak. And then the Global Expo of Botswana was cancelled. This brings in a lot of revenue. So it affected tourism, and most people lost their livelihoods. These were not operational. These were the most hardly hit, although they got relief measures from government, but they didn't really not receive the subsidies. They're only given to locals. So you see how this affected non-permanent residents. Then Botswana has a strong macroeconomic basics, but economy contracted approximately 13%, which is a lot. By last year, when COVID-19 ceased, we had 326,500 cases and 2,783 deaths, and then 323,717 recoveries. And I think we had a few cases of long COVID as well. The COVID impact on mining was minus 33%, trade, hotel and restaurants minus 32.2%, manufacturing minus 10%, and social and personal services minus 4.8%. Tourism revenue fell by 95%. This led to poor mental functioning and poor physical health, affecting quality of life. Quality of life is a matter of concern, and it's affected by both physical, social, and mental issues. So this made Botswana fail to follow up on SDG 10 goals of poverty issues and diseases. With Botswana, although they sort of have policy enactments, implementation lacks, like most African countries. But when COVID-19 hit, there was nothing enacted, because this was like something that had just happened suddenly. And so we decided to do research so that we prepare for future pandemics. So a lot of people wrote proposals on COVID-19 in 2020 and 2021. So we are now coming up with implementation on how to prepare for future pandemics. So the increase, we're looking at increasing the size of workforce as well, and improve health systems and social care through knowledge of the prevalence of variables in Botswana pre-COVID-19 and after the lockdown. Because what we did then, using that the link that I'm going to share, we collected data and we're comparing the anxiety levels, well-being levels, quality of life levels, quality of relationship levels before the pandemic came into Botswana and during the COVID-19. And this was soon after, the data was collected soon after lockdown. So the reason was to identify social determinants of health associated with COVID-19, so as to effective implementation of targets that can work to prevent future outcomes. And then the differences in all variable levels pre and during COVID-19 pandemic were also looked at to show the impact of COVID. And then The other objective was then to devise and plan prevention and intervention strategies to manage future pandemics. So these were the specific objectives. They are not very different from those. So we looked for prevalence for quality of relationships, loneliness, parenting, well-being, anxiety, etc. And what the difference is in outcome variable levels pre and during the COVID-19 pandemic meant. And then we also wanted to find the factors that were associated with anxiety, loneliness, boredom during the COVID-19 pandemic, and also the associations among the social demographics and all the other social and mental variables or the outcome variables. The methods, there's a link that was used to collect data, and Botswana managed to get a sample of 422 participants. There are limitations to this, they will come later. Then this was an online cross-sectional study on personal and family coping, as there was no other means then, because it was in July, August of 2020. Then these were the instruments: WHO 5 Wellbeing Index, the loneliness scale, 3-item loneliness scale, relationship quality index to measure quality of relationships, boredom scale, and the generalized anxiety disorder 7 scale. Then descriptive test correlations, hierarchical regression, bivariable linear mixed effect models were used for analysis. And then at the end of this questionnaire, there was personalized feedback, which was presented at the end on individuals' performance on different variables. For example, some people had low well-being. I remember when I also filled this questionnaire in, and my well-being was at 0, and I was really shocked. I was like, am I dying or something? So I started working on myself as a psychologist. It helped, really. Then the ethics were considered. And then for those who have never been to Botswana, this is the map of Botswana. Botswana is neighbors to Zambia, Zimbabwe, South Africa in the south, and Namibia in the west. And the data was collected in the east and in the south. It was very difficult to send the questionnaire link to up north and wherever. Although it was online, most of the people who responded lived in the capital cities, Francistown and Gaborone. As you can understand, people in the rural areas do not have internet, so that was sort of a limitation. Then these were the results. There was an imbalance. We sent it to the UB community, and we had 56% of responses, suggesting actually that most of them were students. So that led to a skewed distribution because we didn't capture older people, and mostly people over 36, as most of them were between 18 and 36. Then most of them were females, as every other research. You find that more females participate in research. Maybe men can tell us why they don't participate in research as much as females. And then most of them were single. And this, I think, affected our quality of relationship scale and our parenting scale, because we didn't have, we had fewer participants. And then most of them also had no children. So the impact of parenting was affected by the fact that it was also a skewed distribution. But what was concerning in these results was the prevalence of anxiety. It was 46%. It had gone so high, it was actually disturbing, because when we compared it with other countries, others were at 12%, 3%, 7%. I think this is something that needs to be addressed. It's unfortunate we didn't do the follow-up study to see whether the anxiety level had gone down or the prevalence had gone down. So those with severe anxiety symptoms and moderate anxiety symptoms were about 37%, 37 to 38, which is quite high, I think. Then the other variables for anxiety scores pre and during COVID-19, as you can see, it increased from 5.8 to 8.2, and it was significant. Then well-being scores also reduced from 13 to 9.8, and the effect size was moderate. As you can see, coherence-D was 6.6. So it's the same applies to anxiety. The effect size was also moderate. Both on scales, the effect size was small, so I wasn't really worried about this, but it increased from 25 to 96. The same applied to loneliness, then quality of relationships, parenting. All the effect sizes were small in all these other variables. So what was really concerning was the anxiety and well-being scores. And these are correlations between anxiety and well-being. They are also moderate, as you can see. Then we also looked at associations. So I'm giving the associations, sharing the associations with anxiety. So these are the determinants of health that should be controlled. With regards to physical factors, we have age and gender. However, age and gender ceased to be associated after adjusting, I think, because of the limitations I talked about, that these were skewed distributions. Then the ones that were more concerning were the social factors. Switching on and off media, it seems this really affected people's anxiety levels, even the same as well-being levels. Some people were so spooked with the way the deaths were announced on a daily basis, how the statistics were going. I thought it was a good idea, but it led to higher anxiety among us, because we would know that so many people have contracted COVID this week, and so many people have died. So many people are in hospital, the hospitals are full and all that. We've learned this from social media and TV. Then employment also had a great impact on anxiety. Then the finances, I talked about them in the introduction. Then personal and family health concerns. Someone should mute.
Sorry, can you please, Tamina, can you please mute? There, and sorry, Professor Muthefa, you have 2 minutes left.
Okay, so all these were associated with anxiety. Then with well-being, it was relationship status, concern about own and family health, difficulty switching on and off media reporting, change in lifestyle, participation in sports, and resting were significantly associated with well-being. The same were also associated with loneliness, although with a small effect size. So I wasn't really concerned about this one. I was more concerned about well-being. Then the impact of COVID-19 on alcohol sales. We didn't do this, but I included it because it was part of our study, but we couldn't analyze it because alcohol outlets were all closed for more than a year in Botswana during COVID-19. So I wrote Tabela 2021's findings. Then the limitations, I've already mentioned them. Then I'm going on to implications. So the implications for research practice and policy. I talked about the prevalence of anxiety being a concern, so something should be done about that for future studies or for implementation. Then students should also be assessed to check whether the impact is grave. And then methods, they should use stringent measures. They shouldn't use stringent measures for they have negative impact on employment, relaxation, concerns about health and loneliness. So COVID-19 knows no boundaries. So we need free online support services to alleviate fears of the virus. And finally, positive stories that make people hopeful, like recovery narratives, and those that show efficacious coping strategies should be given priority when sharing news on pandemics so that the media doesn't have a negative impact. Then in conclusion, people were already grappling with economic and health issues, let alone problems emanating from COVID-19. So this is basically about it. And that's how I think the government.
You got muted, Professor Mutefa. We didn't catch the last bit. You're muted. Please unmute, Professor Mutefa.
Oh, okay.
Yes.
So where did you last hear me?
Almost at the end.
Okay, I was saying government and stakeholders should work together to plan for future pandemics so that when it happens, we have systems in place and people won't be affected economically, and we have coping strategies in place so that we are not surprised like we did with COVID-19.
Thank you so much. I think we are behind time a little bit. So, and I see there are no questions yet. So maybe we can wait with those questions if they come along after the next presentations. What was very interesting to see from your presentation and from the first presentation, the similarities in experiences between two very different countries, one in Asia, Bangladesh, and then Botswana in Africa. The implications were similar, experiences were similar. You know, strategy for response there's so much that is in common, and that's quite striking. So I hope you will stay on, Professor Mutefa, in case there are questions coming up later on. Is that okay? And I had hoped that we would be able to take a couple of minutes for leg stretch, but I'm afraid we are running behind a little bit. And I hope you all have a glass of water or a cup of tea next to you so that you are still able to hydrate yourself or refresh yourselves. So moving on to the next presentations, I've had the privilege to work with the next two speakers, Mr. Asiful Islam Onik and Dr. Tanvir Ahmed. Mr. Onik is a research associate at the Department of Research, Monitoring and Evaluation in SAJIDA Foundation. He is pursuing the Open to Health, fully funded postgraduate degree in Health Crisis Resilience from the School of Transnational Governance, European University Institute in Italy. He obtained his BSc and MSc in Population Science from University of Rajshahi in Bangladesh. Mr. Onik's co-presenter, Dr. Tanvir Ahmed, is a public health and development researcher currently based in the UK. His primary area of interest is complex adaptive systems, health system research, technology and health, emergency health response, including COVID. He has worked on various research organizations in the UK and Bangladesh, including SAJIDA Foundation. The two speakers will present evidence from Bangladesh on consequences of COVID-19 on mental and physical health. Onik, please start.
Thank you, Dr. Zarina, for giving me the floor. Dear audience, thank you for joining this webinar. Now I am starting our presentation. We all have been affected by COVID-19 pandemic in one way or other. Along with physical and mental well-being, the pandemic has impacted the economy and livelihoods of people worldwide. The adverse impact of the pandemic on physical health has been quite significant in both low and middle-income countries, that is LMICs, and high-income countries. However, the mental health consequences were perceived to be more prevalent among the LMICs. Additionally, both physical and mental health impacts during and after COVID-19 have critically encountered the global and country-specific public health system. So, to address the challenges of the pandemic as well as future pandemic preparedness, greater attention is required on long-term impact of COVID-19. In Bangladesh, only a handful of studies have presented evidence of mental health related signs and symptoms of long COVID, and the investigation is even less on physical health related signs and symptoms. So to address the research gap, this study aimed to investigate the prevalence of mental health related symptoms among previously hospitalized patients with COVID-19 and its association with changes in socioeconomic status and related inequalities in Bangladesh. And the second objective is to assess post-recovery consequences of COVID-19 on patients' physical health over time, such as distribution of physical health system-wise symptoms, onset persistence, and association with patients' socioeconomic profile. Now, we are delighted to inform you that our work on the first objective has recently been published in a peer-reviewed journal named Frontiers in Public Health. In this cross-sectional study, the study population was the patients with COVID-19 who were admitted, received treatment, and discharged after recovery from SAJIDA Hospital. Back then, SAJIDA Hospital was a COVID-19 dedicated hospital in Narayanganj, that is situated near Dhaka, Bangladesh. The duration of data collection was from February to April 2021, and the average period between patient discharge and interview date was 186 days. Due to strict restrictions of mobility and physical distancing at the survey time, interviews were conducted over the telephone. An electronic survey questionnaire was prepared using a web-based survey application called Copo Toolbox. Now, this flowchart is presenting the sample size determination of our study. The final sample size of mental health study was 481. On the other hand, for physical health, we selected only those survey participants, that is 420 patients, who had their hospitalization records. This record included the information from admission, treatment, and discharge forms obtained from SAJIDA Hospital. Now, I will discuss in detail about the mental health study, and my colleague Dr. Tanvir Ahmed will share the findings of the physical health study. As for the study variables, for the mental health study, the dependent variable was mental health related symptoms, and here we used DAS-21 scale. After converting all three symptoms, that is depression, anxiety, and stress, into dichotomous variables, we have finally categorized the variable as no symptoms at all, any one symptom, any two symptoms, and all three symptoms. Below, you are seeing the independent variables consisting background characteristics and changes in socioeconomic characteristics. And in the right side box, we mentioned the statistical methods used for the data analysis of this study. Now, the findings and discussions of mental health study. So, since the background and socioeconomic characteristics of both mental and physical health studies were quite similar, so I will initially present the background and socioeconomic characteristics of both studies. As for the background characteristics, the mean duration of hospital stay of the participants was 12.2 days. Mean age of the participants at the time of the survey was 45.3 years, and most of the participants belonged to nuclear family, resided in their own house, and had more than 12 years of education. The median monthly income of the participants was more than 32,000 Bangladeshi taka, that is around 370 USD, whereas the monthly expenditure was 30,000 Bangladeshi taka, that is around 345 USD. Although more than half of the respondents were in paid employment, about 40% were from the poor socioeconomic group. In the mental health study, we have investigated the changes in socioeconomic characteristics of the respondents in post-COVID situation. We found that nearly half of the respondents reported changes in their income and expenditure. Of them, earnings were reduced for 92% of the participants, while spending rose for 88%. While investigating the prevalence of the symptoms of depression, anxiety, and stress, the figure shows that 45% of the participants reported at least one mental health related symptoms of depression, anxiety, or stress. 11% respondents reported experiencing any two symptoms simultaneously, whereas 12% reported coexisting symptoms of depression, anxiety, and stress at the same time. In order to investigate the association between the changes in socioeconomic characteristics and mental health related symptoms, we have applied multinomial logistic regression analysis. And in this table, we have presented only the significant estimations. I will explain further in the next slide. The results from adjusted multinomial logistic regression show that the older age participants are less likely to report of having all three symptoms compared to their younger counterparts. Similar studies from Japan and Pakistan reported that the level of mental health related symptoms appeared to decline with the increment of age. Similar to other studies from Bangladesh, China, Japan, and Turkey, this study observed that compared to men, women are more likely to report experiencing the coexistence of all three symptoms. There is evidence that in a post-disaster context, women are more vulnerable to mental health related morbidities due to greater workload in the household, increased responsibilities towards family members, and high incidence of domestic violence. The odds of experiencing any one symptom and any two symptoms were significantly higher among participants whose working hours had changed. Studies from the LMICs reported that people with stable socioeconomic status during COVID-19 had less likelihood of developing mental health related morbidities. This fact has also been reflected in our studies. We have also measured the inequality of experiencing mental health related symptoms based on the participants' income, expenditure, and socioeconomic status. If you look at the table, the red marked areas reveal that the likelihood of experiencing any one mental health related symptom was significantly concentrated among the participants with lower expenditure and the poor socioeconomic population. This was also evident in other LMICs. Thus, based on the findings of this study and existing evidence from other LMICs, it is critical to further investigate the nature of the association between economic struggle and post-COVID mental health related consequences in Bangladesh, or tackling the current pandemic situation as well as for future pandemic preparedness. Now, I'd like to invite my colleague, Dr. Tanvir Ahmed, to present the study on assessing the post-recovery consequences of COVID-19 on patients' physical health over time. Thank you.
Thank you very much, Yannick. My colleague has already presented the larger part of the method on post-COVID-19 physical health consequences. So I'll start by introducing the variables first. Next slide, please. So as you can see from this slide, other than the socio-demographic and economic variables presented earlier, a range of physical health symptoms grouped as general and system-specific specific systems were used. Two time variables were used, onset and persistence. Next, please. The group were constructed for analysis. The group were constructed as the survey participants who mentioned about symptoms of physical health. Those who mentioned having symptoms were cross-tabulated to report who had similar symptoms in their hospital admission, treatment and discharge record, and who didn't. Next slide, please. In this slide, I'm showing the distribution of post-COVID-19 physical health related symptom in various groups. Next, please. Note that, next, please. In this table, more than 90% of the participants complained about some form of physical health related issues during the post-COVID-19 recovery period. When matched with hospital admission history, about 25% of them claimed to have developed this symptom after being discharged from the hospital, And with no previous history, a large proportion of people reported about complaints related to cardiovascular system, which was roughly around 94%, nervous system 93%, followed by musculoskeletal systems. Next slide, please. In this slide, I'm showing the time parameters related to physical health related complaints shown in the previous slide in two groups, groups with similar complaints as per hospital records and the group who didn't. Next, please. The pattern for both respiratory and cardiovascular system related symptoms suggested that group with record of similar complaints during hospital admission and stay reported higher proportion of each of onset and persistence categories compared to the group who did not have record of similar complaints. And also the group difference for both onset and persistent categories were not significant on chi-square test. Next, please. In this slide, I'm showing the difference between group with similar complaints as per hospital records and the group who didn't for gastrointestinal and nervous system. Next, please. The pattern suggests that for both gastrointestinal and nervous system related symptoms, group who did not have record of similar symptoms in hospital records reported higher proportion of each of onset and persistent categories compared to the group who had a record of similar complaint during hospital admission straight. The group difference for the persistence of gastrointestinal system was found to be significantly higher among group with no record of similar system in hospital record through chi-square test. Next slide, please. In this slide, I'm showing the difference between group with similar complaints as per hospital records and the group who did not for musculoskeletal system. Next. The pattern suggests that for musculoskeletal system related symptoms, group who did not have record of similar symptoms in hospital record reported higher proportion of each of onset and persistence categories compared to the group who had record of similar complaints during hospital admission and stay. And these group differences for both onset and persistent categories were not significant in chi-square test. Next slide, please. As my colleague and I have shown in this presentation that there is considerable evidence of mental and physical health related post-COVID-19 burdens in Bangladesh. It is also important to note that others have confirmed similar evidence in Bangladesh as well as in both developed and developing country contexts. Next, please. However, there is a notable divide in the existing knowledge pool. A large share of existing literature has reported the burden of post-COVID mental health related issues. Most of the work has been carried out in the context of developed countries, and the share of low and middle income countries is rather slim. There is also notable dearth of evidence documenting the breadth and depth of physical health related burden of post-COVID-19 consequences. Next slide, please. We believe it is important to understand, based on the finding from this study, it is important to understand that the days of the pandemic may be over, but the challenges remains as post-COVID-19 consequences. While the main challenge for Bangladesh and other low and middle income countries is chronic resource scarcity, it is crucial to explore and document the burden of post-COVID-19 mental and physical health related consequences in terms of socio-demographic and economic clustering, guidelines to screen and manage people, especially at the primary healthcare level, by conducting focused population and clinical research. At the same time, it is important to recognize this as a challenge for optimum policy response. For this, dialogue and advocacy actions among all related stakeholders is very important for maximizing the use of limited resources and appropriate resource allocation. Thank you very much. Next, please. That's the reference, mostly for my colleague who presented on mental health findings. And I thank you on behalf of my colleague and myself for your patient hearing. Thank you very much.
Thank you so much, Onik and Tanvir, for your presentations. Given a time constraint, we're still running behind a little bit. I see there's one question from Mushtaq Bhai. I was going to suggest that we move on to the next presentation, but I'll take that question from Mushtaq Bhai. What preparations the country should take to reduce mental stress when the next pandemic hit? Is the SAJIDA Foundation doing anything on this now? Anyone, Tanvir or Onik?
Thank you, Dr. Mustaka, for your question. So I can give a little bit of concept about the preparations that the country can take to reduce the mental health stress. Actually, it depends based on the types of the next reduce mental health stress. Sorry for the description of the audio. So the sorry. So if the next pandemic is not such as infectious, or it could be the airborne or other infectious disease, so it mainly depends on that type of pandemic. So in a basic sense, from the learnings of COVID-19, we can say that most of the people were getting their mental health stress based on their poor socioeconomic status during the lockdown. So if a government or other NGOs like SAJIDA Foundation or BRAC, if they can give some incentives during the lockdown, then in the post-COVID lockdown time, the poor people can get their amenities and they don't have to get stressed due to the lockdown. So I think government and such NGOs should make some amount of incentives stored in their I mean in their storage, so that they can provide some I mean additional incentives to the poor people. And for the second one, we have seen that men and compared to men, women are getting the more mental stress in Bangladesh, and this is also prevalent in other countries. So if we can reduce the household burden of women, and if the domestic violence can be reduced at the time of pandemic, so the mental stress of the specific women can be reduced. And currently, SAJIDA Foundation is constantly observing and investigating the COVID situation using the data collected from during the COVID-19, and based on the data and the analysis and some other studies, we are obviously preparing for the next pandemic. Thank you.
Thank you. Tanvir, the next question is addressed to you, but please give a very brief response. Did you explore why there is a significant difference for gastrointestinal issues or symptoms between the two groups, those who complained about symptoms during hospital stay and those who did not? Very briefly, please.
Sorry, I didn't get the question. I can't see them here. Could you please repeat again?
Yes. Did you explore why there's a significant difference for gastrointestinal issues between the two groups? Those who complained about symptoms during hospital stay and those who did not?
Thank you for the question. I mean, no, we the straight answer is no, we did not yet, because this is a work in progress, and we will be doing more analysis, and we will sure to keep this in our mind. But my as a researcher, my understanding is, because this COVID-19 is a coronavirus, and we know that a whole load of viral diseases are very closely linked to gastrointestinal symptoms because of the cross reactions of immunity and the other immunological factors. We think these might have may have a very important role in long COVID in terms of gastrointestinal systems as well. So this might be the reason. But at the same time, to ascertain this, we will need to conduct more focused biological studies with biological specimen, looking at people with a complaint of post-COVID consequences as well as people who did not, but both having a past history of contracting COVID-19. Hope that answers your questions.
Thank you. And then there was a question if there was any relation between nutrition and mental health. And I don't think you looked at nutrition. So that information was not available for the study. Thank you both. And let's move on to the next speaker. It's my pleasure to introduce the last speaker of this plenary, the first plenary, Professor Shamini Prathapan, who is the Chair Professor of Community Medicine at the Faculty of Medical Sciences, University of Sri Jayawardhanapura, a public health specialist. She's a bioethicist and a journal editor. Of her 18 years of teaching career, she has been working as a professor since 2007 in Sri Lanka. She's the co-editor of the Journal of the College of Community Physicians of Sri Lanka for nearly a decade. She's also editorial member of international and national journals. She will give us an insight on how COVID-19 impacted on mental health in another South Asian country, Sri Lanka. Over to you, Professor Shamini.
Thank you very much, and good afternoon or good morning to all of you all over the world. A special thank you to the SAJIDA Foundation for inviting me and looking forward for further deliberations. And as Zarina mentioned, the contribution of the foundation to the nation and the world is admirable. And Zarina, thank you very much for the kind introduction. So as you all can see, the topic today is the impact of COVID-19 pandemic on mental health issues in Sri Lanka. Now, as you all know, mental health is not new nor newly discovered. So throughout history, every man has faced a number of mental issues, from simple depression to schizophrenia. And since the beginning of recorded times, abnormal behavior has been part of human experience. So we can go back to 17th century, where the treatment for the under the devil's control within inverted commas was really worse than any physical ailment. And many individuals who were suffering from mental illness were tortured in an attempt to drive out the demon, the so-called demon. So when this didn't work, and obviously it didn't, the victims were thought to be eternally possessed and in need of execution. This was not only found in the 17th century, from 16th, 17th, and even in the 18th century during the ancient days of leprosy, with the communicable diseases on the rise, the villagers lighted fire to the houses of leprosy patients. Now we could see that the history repeated itself during COVID-19 period, during the pandemic. The community took the so-called verdict into their own hands, and this was a disturbed findings in our study, where we found that a 52-year-old tourist guide was diagnosed with COVID-19 said, let me quote, "Our neighbors tried to avoid me and my family. They even set fire to my house, claiming that we were spreading corona. We were labeled as corona infected," I unquote. This was seen in a research findings on the paper published by our team on the Journal of Public Health in 2021, which was a qualitative study. Now, in this qualitative study, the majority of the participants in this study were men. It was about 58%, and with a mean age of 43 years, which was more or less a younger age group. In total, up to 1/3 of the participants experienced stigma related to COVID-19 and were discriminated, by the community co-workers, and let me emphasize, also by the healthcare workers in Sri Lanka. There was a quote by a cancer survivor. Let me quote, "When I came home after recovery, my neighbors said hurtful things. Some even asked, quote, 'Why are you not dead yet?' I unquote." So patients were isolated and discriminated from the healthcare institutions, workplace, and the community due to COVID-19, even after full recovery. Now, unlike the first presentation, unfortunately, Sri Lanka did not find any positive views on stigma related to COVID-19. Now, social discrimination, what we found from these studies included barriers in accessing basic needs, insulting, blaming, spreading rumors, receiving no support during emergencies, and defaming. Stigma and discrimination at workplace was another problem that we had to look into. Now, the stigma that we looked at leads to, or there were types of stigmas that we looked into. One was anticipated stigma, where a person avoids testing for SARS-CoV-2, which we know as public health specialists that it has many repercussions with regards to public health and with regards to prevention of any pandemic. Perceived stigma, on the other hand, is when patients and their families feel judged by others, whether they are infected or exposed, whereas experienced stigma it leads to is where they feel excluded, isolated, discriminated against by their household or by their community. Now, all these three stigmas lead to internalized stigma, where the patient feels shame and self-rejected. This internalized stigma is what needs to be prevented, because internalized stigma leads to depression, which in Sri Lanka is on the rise. And the anticipated stigma and the perceived stigma leads to anxiety and stress, again, which is on the rise in Sri Lanka. At the beginning of my presentation, so why did I say that the history is repeating itself? It's not only in Sri Lanka. Giovanni, in one of his articles from the European country and Australia, also described COVID-19 as a witch hunt. Thus, we could see that the world was no better. And we also see highest rates reported from Jordan, Lebanon, Bangladesh, and UK, all which accounts to stigma with around 60-odd%. Sri Lanka, I feel, was a little bit better, being an island, where we had a success in the containment in the first wave, which gave Sri Lankans more time to overcome the fear of COVID, which we feel was the main factor for stigma. Further, the Ministry of Health in Sri Lanka disseminated accurate information with several risk communication strategies to allay the fear and prevent erroneous assumptions on COVID-19. But still, we felt that it was not enough for us to overcome stigma and the psychological distresses that were accompanied with it. Now, during the first few months of COVID-19 in Sri Lanka, we had returnees from overseas and contacts of local patients were quarantined, like in any other countries, in designated quarantine centers for more or less, it was at the beginning for 14 days, but it was brought down to 10 days when we couldn't take the loading. So by the 1st of April 2020, we had about 40 quarantine centers, and these centers provided separate rooms, food, water, healthcare, all free of charge. And Sri Lankans who arrived at the airport from all over the countries were quarantined and isolated in camps. Depression, anxiety, and stress set in. And as per the DAS, Depression, Anxiety, and Stress Tool 21, we see that depression was found in 6%, anxiety in 2%, and stress again in 6% of the participants respectively during the quarantine period. and with all three in about 8%. So like Anik's presentation, I guess Bangladesh and Sri Lanka are more or less equal, where they had, I think Bangladesh, you all showed 12, and we here see about 8% here for all three. Now, we did follow them up for 6 months. And although the follow-up brought anxiety to 0, prevalence of depression and stress continued in 1.4 and 3.6% respectively. Again, I see a similarity with Anik's presentation and with what we had done in Sri Lanka. Females were significantly higher to have depression, anxiety, and stress, just like Bangladesh. And another factor that we found were those who were in quarantine for more than 10 days, because they must have thought that that's the incubation period. So those who were in quarantine for more than 10 days were also shown to have higher rates of depression, anxiety, and stress. And stress was also higher in those with comorbid medical conditions. We also looked at the coping strategy used during quarantine and in the follow-up. And unfortunately, we found that denial was seen in 64%, and substance use was found in 80% of the participants, not making the follow-up picture look very pretty, because Sri Lanka was already having a higher rate of substance abuse. So this is not helping us with the prevention methods. So with the coping strategies and the psychological distress of depression, anxiety, and stress in COVID-19, it is obvious that all the mental health issues before COVID were on the rise, and now after COVID, it is further at an aggravated level. We also targeted the healthcare workers and assessed the psychological distress of doctors and nurses during the first lockdown. Among a sample of 385, stress was found in about 11%, anxiety was found in 16%, depression again in another 14%, and stigma was experienced in about 30% of healthcare workers. Now, among these healthcare workers, 8% were not accepted into the shops in the villages. Those are nurses, doctors, and anybody working at a healthcare institution, a government healthcare institution, of which 8% were not accepted into the shops. 3% were asked to leave their place of accommodation where they were on rent, and these rents were close to the hospitals. And 15.5% or nearly 16% felt that their families were discriminated in the villages just because they were healthcare workers. We need not have the history repeat itself. With the unaccountable number of messages in the social media especially, and with the increased prevalence of mental health disorders and mainly the long-term outcomes of long COVID, warrants evidence-based primary preventive measures with stakeholders. As you all know, Sri Lanka offers free healthcare services like in most other countries in the Southeast Asia. And this has initiated outreach clinics, community support centers, and almost all health divisions. But the main service objectives of these hubs are to promote mental health well-being and to improve the access for care of those who have already found to be having mental disorders. So during a future pandemic, a new pandemic that could set in, or with the long COVID, where with the stigma public about the importance of easing stigma and discrimination so that we can undergo screening and enabling successful treatment for those with whether it be long COVID or in another crisis that would come with future pandemics. Thank you.
Thank you so much, Professor Shamini. It's very interesting, but not unexpected that there's so much similarity between The three countries that from where evidence has been presented today is Sri Lanka, Bangladesh, and Botswana. The contributory factors may be different in the three contexts. In Bangladesh, for example, surprisingly, increasing age was not a contributory factor to a greater probability of reporting depressive anxiety or stress-related symptoms. And also the kind of services there is to address these issues are different in the three countries. That itself also sort of leads to maybe we can learn from each other in relation to response to these challenges. Thank you so much. I see that there are not yet any questions from the audience, and Professor Shamini, if you're staying on for the next those questions after the session. So before I hand over to Dr. Mushtaq, I would like to thank all the presenters for their insightful presentations, and of course the audience for posing questions and comments of high importance. It's apparent that coordinated efforts by linking different stakeholders at the early stage of a crisis is vital, for efficient and effective response. It's also important to recognize that we have seen from the different presentations that the pandemic may be over, as declared by the WHO only a couple of days ago, that its impact on both physical and mental health can be long lasting. However, these dimensions of health need to be teased out to understand the impact on specific aspects of health in order to design targeted interventions. For example, in case of mental health, what we've seen, whether it's depression, anxiety, or stress, which is mostly affected, and how are those to be addressed? Well, this brings to the end of the first plenary of the webinar. It's my honor to introduce the chair of the next plenary session, my mentor, Professor Mushtaq Chaudhry. Professor Chaudhry embodies tremendous expertise, not only in academia, but also in connecting research into action. He's professor of population and family health at Columbia University in New York. He's advisor to the James P. Grant School of Public Health at Brak University in Bangladesh. He's adjunct professor, College of Health Systems Management at Narsarsuan University in Thailand. He's also founder of the Bangladesh Education Watch and Bangladesh Health Watch, two civil society watchdogs here in Bangladesh. A large part of his career was at BRAC, from where he retired as its vice chair. He was also senior advisor and acting managing director at the Rockefeller Foundation and a fellow at Harvard University. Over to you, Mushtaq Bhai.
Thank you, Zarina. Thanks for the long introduction. It's really my privilege to welcome you to all to this the second plenary of this webinar, which is the second part is titled "Pandemic Lessons," the COVID-19 pandemic lessons from the low and middle income countries. And under this, we have two papers to listen to. But before that, I want to congratulate the SAJIDA Foundation for organizing this very important webinar. We know SAJIDA Foundation as a kind of a doer. They have programs, intervention program in many parts of Bangladesh, but they're not only been very active in response to the COVID, but we are seeing that they have also been very active in documenting the evidence of how they sort of tackled or tried to respond to the pandemic. This is going to be very helpful for containing and planning for the next pandemic whenever it happens. So I congratulate the SAJIDA Foundation for doing this. And I'm also very happy to be chairing this session, and which is organized by the SAJIDA Foundation, which The foundation carries the name of a illustrious lady, of course. I have had the opportunity to meet her a few times, and also her illustrious husband, the late Sayyid Humayun Kabir, who was the chairperson of BRAC for many years. And I had the opportunity to work with him on the board of BRAC for several years. So it's really a big luck and privilege for me to chair this session. In the first session, we have heard 4 papers representing countries from like Bangladesh, Botswana, and Sri Lanka. And now we have 2 papers to listen to. And the first paper, I think, is by Dr. Tanveer Ahmed, and the title of his paper is LMIC Response to COVID-19 Pandemic, Lessons to Learn from the Experiences of a Bangladeshi NGO. I presume he is talking about the SAJIDA Foundation. And I don't, Tanveer has been introduced already in the previous session, but I just wanted to mention that I had the privilege to also work not very closely with him, but he was anyway privileged to be students of 2 very important institutions. He did his MBBS from Ganashastha Kendra, whose founder, we just lost him, Dr. Zafrullah Chaudhry, and also his MPH from the BRAC School of Public Health. So we are very proud of him. He's doing very well, excellently in research in his post doctoral days. And I'm very pleased to introduce him and ask him to present his paper. Tanveer.
Thank you, Professor Chaudhry. It is a very a big privilege for me to be in your plenary session. Thank you very much. So as you can see, that's the title of my presentation. Next slide, please. We have already talked about COVID-19, and we know that it has been very devastating for the low and middle income countries. There has been 4 times higher mortality compared to richer countries, and complete stoppage to daily lives due to continued lockdown. This resulted challenges includes provision of emergency healthcare, mass communication for behavioral change, keeping economic and existing health and development activities ongoing, etc. This required additional resources, causing the capacity of the low and middle income countries stretched beyond the limit. Next slide, please. In spite of resource scarcity, as soon as the first case was identified in the early March in 2020, Bangladesh acted fast. The response plan was called Bangladesh Pandemic Response Plan, or BPRP in short. A range of emergency measures were taken, such as the use of personal protective equipment, or PPE, setting up COVID-19 wards, screening facilities, enforcing social distancing, and of course, rounds of stringent lockdowns. This resulted in losing jobs and breaking down of distribution chains, among other economic impacts. By the first few months, about 24.5 million new poor were added in the country. In addition, widespread mental and physical health-related issues increased the demand of healthcare, overburdening the system and caused restricted access to healthcare. Next slide, please. In the context of resource scarcity, the government of Bangladesh responded together with the local and international NGOs. However, observations suggest that NGO response have largely been focused on their own area of work rather than contributing to the organized effort aimed at strengthening the national response. Recognizing the need for multidimensional approach, SAJIDA Foundation, which is one of the largest local NGOs in Bangladesh, joined forces with the government of Bangladesh, and their effort has been well appreciated. In this study, we have explored the underlying philosophy aspiration, and strategy behind SF's response to the pandemic in Bangladesh. Next slide, please. This was a case study, and the data was collected from September to November 2021. And that data was collected in 3 sequential steps. First, a list of all activities were prepared by reviewing relevant organizational documents and informal discussion with relevant SF staff. Then, 2 district hospitals were observed using structured guideline where SF helped setting up dedicated COVID-19 wards and ICUs. And finally, a series of key informant interviews were conducted. Next slide, please. Altogether, 15 interviews were conducted with 3 groups of people, 3 groups of staffs, frontliners, managers, and leaders. Analysis was done using 4 themes: why and how SF initiated their response, changes, adaptations made to its usual activities, how SF response was designed, what challenges were anticipated and how those were overcome, and of course, employees' perception of the response. Next slide, please. SF initiated 3 types of COVID-19 response. Number 1, providing direct health support such as healthcare counseling, healthcare counseling, safety measures like PPEs, etc. Number 2, provision of infection prevention and risk reduction services such as vaccine registration, promotion of hygiene behavior, etc. And number 3, social services for the vulnerable households such as food, education, and financial support, etc. Next slide, please. Based on the findings, 3 considerations drove SF's response to COVID-19. At the beginning, the central leadership had a thorough discussion with within the organization, which helped them to identify the nature of the challenge brought on by the pandemic, what was needed to be done to remedy it, and who needed help. Then, discussion with field staff and other development partners, SF consolidated their approach based on their own expertise and learning from others. Finally, they designed their response by improvising on their own organizational motive. As one of the participants mentioned, our mission says we will improve quality of life through sustainable and effective interventions. But at that time, we were not thinking of sustainability. We were concerned about whether it was effective. We focused on effectiveness, and for that, we exerted a lot of labor. Next slide, please. From the very beginning, SF's response considered 4 areas to respond as quickly as possible. Number 1, they recognized the importance of information and awareness amidst the surge of misinformation in the country. Number 2, a formal partnership to work with the government to expand and initiate COVID-19 related healthcare. 3, importance of telemedicine for remote access to healthcare, especially amidst lockdown. And 4, the importance of impact of COVID-19 on people's life, and thus non-health responses such as providing additional support, finding solutions together with the community, and promoting new normal lifestyle to help people cope with the infection prevention measures, and all these were initiated. Next slide, please. Based on the finding, SF designed their COVID-19 activities through pooling of resources and capacity. For funds, they use their own money as well as donations from individuals and local and foreign corporate offices. And to maximize capacity, they share tasks and expertise with the local community and other NGO colleagues. As one of our participants mentioned, we always maintain communication and connection with other organizations. We spoke to them to identify the areas in which they required support. Where are the marginalized communities? At that time, we signed an MOU with them. Through the MOU, we provided services with the organization or with them. Next slide, please. Safety of employees was found to be at the heart of SF's response. The idea behind this was safety of own employees makes a motivated workforce to combat crises like pandemics. In doing so, SF made provisions for working from home, supported personal hygiene measures by setting up hygiene stations, safe working at the front line through the use of personal protective equipment, making healthcare provision for the family of the frontline workers, and of course, provision of food and accommodation for safe isolation when needed. Next slide, please. SF response was also based on adjustment of usual organizational processes through regular communication between the top management and implementation team, decentralization of decision making, and creativity, innovation, and out-of-box thinking for quick decision making. This actually helped SF from quick hiring to procure logistic in the time of need. One of the participants mentioned central to SF pandemic response was good leadership, which enabled prompt decision making, something which was stressed from the very first meeting in relation to how SF should respond to the challenges of the pandemic. Next slide, please. It is important to understand that there is a considerable dearth of evidence, especially to devise an organized effort in an emergency like COVID pandemic in the context of Bangladesh and other low and middle income countries. Findings from this study suggest that working with government to initiate a comprehensive response by NGO can work. Considering this, we believe a framework of such an approach, a response can be devised. Next slide, please. This framework has been named as 4C framework. Next, it starts with capability assessment, which helps in defining the problem and identifying one's strength and other strength. Then comes collaboration for resource pooling and effective implementation through task sharing. Next is compassionate leadership that ensures social and health-related safety, which helps fostering a motivated workforce. And finally, communication for effective decision-making and continuous monitoring. All these C's together can become the basis of embarking on a comprehensive approach. Maybe you can call it 5th C, by NGO in responding to emergency. Next slide, please. This 4C framework can be useful for the government, NGOs, and other policymakers. We believe it can be very helpful for planning, coordination, and supervision of emergency response in a pandemic for a resource-poor setting like Bangladesh. Next, please. These are the references that I used at the beginning. And next, please. Thank you very much.
Thank you, Tanvir. It was a very interesting presentation, and I like the 4C framework that you have devised on the basis of the work that SAJIDA Foundation has been doing. We don't have any question asked in the chat box, but let me start by asking you a question, taking advantage of my position as the moderator. I mean, when we talk about NGO intervention or NGO sort of involvement in the pandemic, we have seen this time that the involvement of the NGOs in general has been very sort of it wasn't like in the past, for example, when we had flood or cyclones and so on. And one of the reasons for this low lukewarm response from the NGOs was the lack of funding from the donors. I know SAJIDA has its own source of funding, but did you try to get funding from the donors at all? So that's the first question. And second, of course, is can you tell us a little bit about the scale of the activities that SAJIDA had during the pandemic?
Right. Thank you, Mustafa. I mean, this is a very interesting question. Honestly, the first part of your question, I don't know. My hunch is, as a researcher, and My hunch is this is one of those occasions where the donor countries as well as the recipient countries were facing an emergency. So funding might have been affected by that because they were already pumping money in their own country, tackling the issue there. So countries like Bangladesh with resource scarcity kind of left behind a bit. That's again from my hunch, my gut feeling. That could have been a reason why when we saw NGOs responding very actively in an emergency like cyclone or flood before, was not like that this time. At the same time, I blame the surge of misinformation and lack of knowledge on the issue. So what happened? I mean, before, like, because Bangladesh has a long experience of combating with the natural calamities, I think handling an infectious pandemic like COVID-19, the NGO's existing knowledge fell a bit short. So coupled with the knowledge lack as well as the funding issues might have caused NGOs not really responding the way they could have done before, which they did before. The other part of your question is, I mean, of course, SAJIDA Foundation received some amount of donation from various local and corporate sources. But I think what SAJIDA has done, being very strategic in managing these resources and pulling these resources, of course, they had the seed money from their own source to get the ball rolling. So that started all the activities, and they're very I'll say very strategically targeted individual as well as corporate donors rather than going to big donor organizations who were already engaged with giving funds to their own countries as well as other areas. That's how. And there were more. The big donor agency we see during the formation of BPRP, we saw that during March 2020, the donor agency were actually focused on funding the government so that the government can later respond more accurately. And regarding your third part of the question, that scale, SAJIDA Foundation did quite because SAJIDA Foundation currently covers roughly about half of Bangladesh through their various programs and activities. So their non-health programs were more or less scaled up in all their working areas, and they also kind of partner with the local partners as well. And regarding specific hospital-based care, they definitely set up a very dedicated hospital, a separate full hospital in Narayanganj, one of the neighboring districts to the capital Dhaka. But also, they could scale it up in other areas, but rather doing that, what they did, when the pandemic started expanding through the bordering districts, they very strategically expanded their program in those bordering areas, helping those government hospitals to set up dedicated COVID ward, including ICU. So that's how they basically did.
Thank you. Thank you, Tanvir. That's very helpful. We have to move forward, I think, with our next presentation. I'm very pleased to introduce our next presenter. Indranil Mukhopadhyay is yes, Indranil. Indranil is a professor at Jindal School of Government and Public Policy, Jindal Global University, which is based in Haryana in India. Indranil teaches public health, health economics, development economics, political economy of health, and comparative health systems at the JGU, which is the Jindal Global University. Indranil has more than 17 years of research and teaching experience, and has led several research studies on health financing and policies. He is the co-editor of Jindal Journal of Public Policy. He is also part of the National Coordination Committee of the People's Health Movement, the PHM, India chapter. and executive committee member of the All India People's Science Movement. So he's a gem, and we are very pleased to have him in this session. Indranil, it's all yours now.
Thank you, Professor Chaudhary. Am I audible?
Yes.
Okay, thanks. And it's a great honor, and thanks to SAJIDA Foundation, Tanvir Bhai, and all of you for giving me this opportunity. I'm quite thrilled to be part of this whole process. Uh, and what I'm going to do is, and I'm quite in, like, I'm going to share some of the critical issues that we confronted while working with various networks and movements during the COVID time. And also in some way, Tanvir Bhai had given me this brief that what worked, what didn't work, and lessons for future. So I have tried to develop few themes around those concerns and ideas, and I'll try to present. I'm sorry, this is not a research paper, but it's like some of the issues that we have discussed. And one of the things when we start discussing the India experience during the pandemic, one of the things that really worked, I feel, is the vaccine experience in India. And it was one of the largest publicly provided and publicly financed and publicly provided vaccine with, and this was the result of strong protests and advocacy from various rights groups and civil society. Initially, government's response was that vaccines should be given to through various channels, and states have to compete with each other to get vaccines. But that over time replaced with very important staggered approach and prioritization and entirely publicly funded provided. And some of this could happen because India had the domestic capability of producing vaccines, though the technology came from external sources for one of the major vaccines, but then we could also domestically invent and produce vaccine. And if we see compared to many other developing countries, India, countries like Bangladesh, and also in our region, Nepal, China, Cuba, and in Latin America, Cuba could do well compared to countries in Africa. And that's where I think if we look at the issues of vaccine grab and then compare some of these developing country experiences, I think the issue of domestic capacity and the ability of the government to finance and provide vaccine became very crucial. And if any lesson has to be drawn from this vaccine experience, is that we need to develop South-South cooperation in science and technology, because we saw in this period also that vaccine appetite being played out, and the way vaccine grab happened during this whole episode. So some of these inspiring developing country experiences can teach each other how South-South cooperation can be fostered. Other important, and I'm starting with some positives and then I'll go back to some critical reflections. Other positives from what worked during the pandemic in India, particularly the kind of effort that the frontline workers really put in during the pandemic period, often risking their lives. They faced a lot of discrimination, and we saw the earlier studies from Sri Lanka that how they have also faced huge mental health and safety-related challenges. And there were hierarchies within that also. And much of the groundwork were done by workers, what we call accredited social health activists or ASHA workers in urban area, who are not even recognized as workers. They're seen as social activists and volunteers, and they are paid very little, but then they put aside a lot of risk and combated the pandemic very, very strongly. and that their work has also been recognized across the world by WHO and other entities. So, what is the lesson from here? If we want to really, I think the frontline health workers, their importance in health system has been recognized more than ever, and we need all this contractual workers, and majority of them are women. They should be regularized. They should be provided decent working conditions and protections for various work that they are doing. And that's a crucial lesson that we should learn from the pandemic, because they faced a lot of hardship. Often they faced retrenchments post pandemic as well. The other lesson that we should really draw from India is that how dysfunctional, poor, publicly provided primary care can lead to overwhelming burden to the secondary, particularly tertiary care. This had been a chronic problem, but we saw particularly during the second wave, the kind of leveler the second wave was in India. Even if you had a lot of money, you could not get any hospital bed or decent quality care, be it in public sector or in private sector. And one of the major reasons was lack of, in particularly in urban area, lack of good primary care and preventive care systems. I think that's where we need to really focus on. And whatever response that we saw during the pandemic was from the publicly provided government services, but then that response, as I said, was inadequate significantly. The other important concern of the came out from the response was that much of this response to COVID came at the cost of routine care for maternity and child health services, family planning, tuberculosis, dialysis, cancer care. All of these suffered immensely during the time. And TB has become there is a lot of resurgence of TB in India, and I'm sure that would be the case in other countries also. And essentially, the lesson has to be there. We should strengthen the publicly provided, resilient, preventive, and primary care system. We should increase public investment on health. India spends one of the least in terms of as a percentage of GDP. Bangladesh is also close by, but countries like Sri Lanka or Nepal spend more as a percentage. We also have some good lessons from the states like Kerala, Tamil Nadu, actually who had been consistently invested on primary care systems, good public system, could do well, while many other states couldn't. Even rich states like Maharashtra, Gujarat, actually couldn't respond to the pandemic well. The hospital admissions rate and hospital level fatality rates were much higher in states like Gujarat and Maharashtra compared to what Kerala and Tamil Nadu could ensure. The key point about particularly the lesson from Kerala has been a participatory decentralized system can really help tackle the emergencies like the COVID. And we need, if anything, we need to develop, particularly in this region, but in LMICs, a deep sense of democratization and decentralization of public health systems. And India should take lessons from Latin America here as well. But then what didn't work? One of the major things that didn't work in India was the credibility of our death numbers. And the government's response had been of denial. Several research studies, WHO supported studies, various other researchers actually said that our death records are abysmally low, and the actual estimate would be several times higher. If you look at one simple graph, these are district level estimates. The graph on the left side, the reported number of deaths and the excess deaths that took place during 2020, sometimes they're 1,000, 7,000 times higher. For instance, district like Amethi recorded 39 deaths, whereas there were 13,000 excess deaths during this period of time. So huge underreporting, and the key lesson here for us is that we need universalization of death and birth registration, particularly in the rural areas. We have states like Kerala where death registration is 100% to 95 to 100%, whereas UP and Bihar, almost half of these deaths are not registered. We need extended levels of transparency here and evidence-based approach to policy and program. The pandemic became politically so sensitive issue that had repercussions with the level of transparency we saw from the government. And then we all know, and I'll skip this, we all know the plight of the working people. Millions were suffered as a result. And one of the major lessons that we need to draw from the suffering of the people, the closure of schools, the disproportionate burden on women, the lesson for us is that we need expansion of social security, unemployment benefits for informal sectors. The large majority of the workforce in our subcontinent are actually informal workers. There are states which are starting urban employment guarantee programs and expanding the urban amenities for poor, but the COVID remains a big eye opener for the world and for our people, how badly the living conditions, how bad is the living condition of majority of informal workers. Okay, we saw a lot of authoritarianism. We had we had a disaster management act that was implemented in this country, where some of the constitutional responsibilities were overwhelmingly shifted towards police and the organs of state. We saw enormous human rights violations. Migrant workers were subjected to the kind of humiliation and unscientific methods of, I would say, quarantine, disinfection, infected they were. So a lot of humiliation and human rights violations. We saw a lot of anti-science propaganda, misinformation, and one of the consequences of misinformation in the policy making was school closures. Many experts believe that schools should not have been closed indiscriminately and should have taken local level approaches towards school closure. But that actually affected generation of children significantly. Their educational outcomes have been poor, as we all know. We also saw in the country extended communal polarization during the period of time. And some of these have been highlighted in the latest Lancet editorial that came 2 days back on May 6th. So we need greater transparency of information dissemination, understanding of people's perceptions and beliefs, and evidence-based dissemination. And we saw during the initial phase of vaccination, there were a lot of hesitancy because of the misinformation that was spread. On the other side, we also saw a pandemic of inequalities folding out in India. We saw that profit rates increased exceptionally during the first year of the pandemic. We saw that profits of some of the vaccine manufacturers globally increased many fold. And we have discussed many other forums we have talked about. I think this is the time where developing countries like us, LMICs like us, particularly in this region, we should take bolder measures to tax the super rich, fund people's needs based on the tax proceeds, and we can think of various such kind of taxes. Professor Chaudhary, please stop me at any point, and I can keep going on this, but I see I've already crossed my limit of 10 minutes wave, so please feel free to stop me.
Yeah, you have one more minute. Is that okay?
Okay, just 2 minutes maybe.
Okay.
And one of the things we compromised on the routine disease surveillance data system, the IDSP, Integrated Disease Surveillance Project, and that actually was detrimental in local level planning and action. I think we need to strengthen those. And in this period of time, we saw that our over-dependence on the private for-profit sector had created major havoc. There were overcharging, irrational treatments, there were overemphasis on tax-funded insurance schemes, but I think the private sector really didn't have the means or the intention to deliver, and that needs to be regularized. Regularized for quality, adherence to standard guidelines and rate rationalization is key while building a health system on social solidarity. We have talked about self-reliance as a key issue. We need to extend it to medicines, vaccines. India, Bangladesh has very interesting experiments with this, and we need to learn from the experience. I'll close by saying that I had the privilege to meet late Zafarullah Chaudhary when we had the fourth People's Health Assembly at Dhaka, and I can't ever forget, we as PHM ever can't forget the role played by Dr. Chaudhary, but also Brack University for, in a span of couple of days, how they managed to shift the venue of the People's Health Assembly, which had participants from 70 countries across the world and almost 1,200 foreign participants. It was a fascinating experience to be there, and also a similar experience today here sharing the platform with you all. Thank you so much for giving me this opportunity.
Thank you, Indranil, particularly for remembering those days when the People's Health Movement conference had to be shifted overnight from Gurkhasta to Brack. But hopefully those will never happen again. But unfortunately, Dr. Zafarullah is no more there, and we miss him a lot. Thank you for your wonderful presentation. It is wonderful. It is a good snapshot of the experiences, I think, that we are hearing about many countries, and we have heard about Botswana, Sri Lanka, and Bangladesh, for example. This is a good experience, a good reflection of the experiences that we have. I don't see any question for you in the chat box, but I do have a question for you. The question is that in Bangladesh, we have seen that there are many research institutions in this country which are sort of run by the government, for example. But unfortunately, we have seen a huge failure on their part to really provide evidence on the progression of the pandemic as the pandemic sort of progressed. And they're not being able to really help the government and the policymakers of what to do. So is that the similar kind of experience that you have in India, that you have also dozens of research institutions in many parts of India, of course? Can you say, quickly?
Very briefly, my personal reflection, the Indian Council of Medical Research funded institutions, actually, some of them played role in the vaccine discovery processes. Some of the collaborations happened on that front, some on devices as well. They also helped set up guidelines which got changed as our lessons were improving. But also, I would highlight that our research funding had been actually pre-pandemic was cut significantly. So some of these research institutions were really weakened. Not that they were doing great work, but also they had faced difficulties in managing support. A lot of actually insight came from the civil society. But then there was very little interaction with the state and the civil society as a critical. There is that disconnect that prevails in India, unfortunately. And and there is also a bit of mistrust on independent research and findings in India. So even it becomes very difficult to be in a public funded institution to say something critical, reflective, which brings out truth. And that sad reality prevails in India.
Thank you, Indranil. We have two questions in the chat box. The first one is from Tanveer, who said that Professor Indranil has nicely highlighted the politics of pandemics in India. It will be nice to hear in his opinion on what India has to learn from it and his advice to Bangladesh health system from the politics of public health pandemic viewpoint. Over to you.
I think this is a bit overwhelming question to me, relatively inexperienced, but I think there is a lot of shared learning between India and Bangladesh. Particularly, we were at times leaders of the generic medicine front, both India and Bangladesh. We have played a pivotal role in that. I think I think there is a need for South-South collaboration. Today, I think some of it needs to be fostered, strengthened, and other issue is I think what I can also say that India can learn a few things from Bangladesh. The experience of civil society, how the civil society contributes to the nation movement, is recognized much more in the Bangladesh context than India. I think that also needs to be somewhere bridged. But I think both the countries need to strengthen our data systems well, and that would probably help mitigate, understand, identify early identification of pandemic. And we have a lot of migration between the two countries. We need to work together more systematically. I think not only between India, Bangladesh, but in South Asia region as a whole. We need to probably build the cohesive strategy to deal with future emergencies.
Thank you. We have another question from Dr. Zarina, who is asking, how is the impact of school closures being felt now?
I think, as a development economist and health economist, I feel this was one of the saddest, long-lasting consequences. We in IPSN, All India People Science Network, we are running trainings learning centers for children. They're still coming back to our learning center. These are not funded activities, locally mobilized resources, very little resources, but children are coming back because they really lost many crucial years of the life. And learning outcome, I think we should talk about learning outcomes, but that has suffered significantly. At various levels, we see that panning out. For girl children, they were pushed to marriage earlier age. That's a particular gender-based situation and discrimination they faced. We saw increasing incidence of child labor in pockets, though we don't have, our data system has virtually collapsed, so we can't really substantiate any of this. But our work in various urban settlements suggests that child labor has increased. It is going to have long-lasting impact, and unfortunately, the spirit of right to education couldn't be upheld in this period of pandemic.
Our schools in our country, for example, in Bangladesh, were closed for 2 years. That's probably one of the longest, other than Philippines, I think. So we really lost a lot of time for there is a suggestion from Zarina that any presenter want to say a few words before we conclude? We have 6 presenters today. Any final, Professor Magan or Indranil? Shamini?
Yeah, I'll say something. Thank you, Prof. Chodebri. I've cited you a lot in my papers.
Okay.
Anyway, thank you, SAJIDA Foundation, for inviting us. It was very informative and it's nice to network. You should do that more often. And we also are so happy to have heard what's happening in Bangladesh, what's happening in India, and what's also happening in Sri Lanka in one sitting. It's actually eye-opening, and some of the experiences, like Zarina said, are very similar, although I think some countries were more hit by COVID than others, maybe because of the huge populations. Botswana is a small country. We only have 2.5 million as compared to Bangladesh, India. There's so many people there. Thank you so much. I've had a lovely time and I've learned a lot.
Don't have that.
Yeah, you don't have diamonds, unfortunately. But thank you so much for inviting me.
And a final.
I was just wondering how the SAJIDA Foundation overcame the NCD crisis during COVID. Were you all able to treat them? Because we find a sudden increase of, unfortunate outcomes after the lockdown because they don't come to the hospital. How did SAJIDA sort of, that was the reason that I just put my hand up at that point when Tanvir was asking, was presenting. Tanvir, maybe you could answer.
Tanvir?
Right. Thank you, Professor Patapan. I mean, Bangladesh, what I think, this is my opinion, I do not have specific scientific data on that, but this is based on my observation. One of the strengths of Bangladesh health system is it's beautifully designed primary, secondary, tertiary. We can go on criticizing about the quality or all the existing inequalities. That's true. But because of that system, and also recently there has been a huge development on the road networks and stuff, so that has also made access to services. So I think, and also in the 80s, Mushtaq Bhai is one of the champions there for popularizing simple solutions like ORS to really making it a public health product. So the people of Bangladesh is already used to hearing public health messages, getting into the, some sort of a care seeking within the umbrella of a care seeking pattern. So I think, although because of the lockdown, the care seeking was heavily restricted, but right after the lockdown, we are seeing it's gradually catching up. We're looking at, mothers are bringing their children for immunizations like they used to do before. So things are catching up. And thanks to a huge network of development workers who goes to household, door to door, making all these things. Maybe Mushtaq Bhai can add something there.
No, I think, the one of the reasons why Bangladesh has done well, despite all the problems, is the active civil society organizations here. And you have heard about SAJIDA Foundation today. So that's said to be one of the reasons of why Bangladesh has done well. But that is being challenged now because the space that the state created for the NGOs is shrinking. So we have to see what happens in the future. And also that most of the NGOs are supported by Western donors, and they have their own problems, as Tanvir was saying, the impact of the COVID and also the Brexit and the Ukrainian war. So all these are really sort of not helping the NGOs at all. So we have to see how this shapes up, for example, in the future. But we are hopeful. Well, that things will turn up in the positive direction for all of us, and we are kind of very optimistic about what our future. It's 20 minutes past our scheduled time. So I don't want to say sort of conclude because it has been such a rich discussion and presentation of facts and about I haven't really recently attended any COVID related meeting, But now that COVID is over and we have a first reflection of what we have seen happening in the world. I was looking at the worldometer this morning, and it says that there has been 687 million cases, and 1% of them died. Although we have heard from Indranil that the actual number of deaths will be manifold higher than that. But we hope that there will not be any pandemic in the future, and if it happens, we'll be much more prepared, hopefully, for the future. So I wanted to thank you all. Thanks to SAJIDA Foundation for giving me this opportunity, and thanks to all the presenters. I don't want if Zarina or Shamira want to say last word.
I think your last words more than suffice, Mushtaq Bhai. I just want to echo what I think it was Professor Shamini or Professor Mutefa who said. We have now created a network through this webinar. And I hope that SAJIDA Foundation can take the lead in moving this network forward, and with future, if not pandemics, but future crises or future emergencies in mind. How do we move forward with coordinated efforts between people who have experience and knowledge and expertise on from various fronts? So thank you all. I would like to personally thank each one of you, the presenters, and of course, SAJIDA Foundation. Shamira.
No,
Shamira,
thank you.
the
Thank
final
you,
words.
everyone. Sorry, Mushtaq Bhai, you were saying something?
No, the final words from you.
Oh, okay. No, thank you, everyone. Really appreciate today's webinar and the rich discussion we had. And I think special thanks again to Dr. Mushtaq and Dr. Zarina for facilitating the discussion. I think we had these interactions, the conversations, because there was this facilitation. Without that, it wouldn't have been such interesting ones. So with that, I would like to conclude the session, and thank you everyone who have joined us today, who have listened to us, and all the presenters and the chairs. Thank you so much.
Thank you.
Thank you.
Bye.
Have a nice
Be
day.
well. Be well.
Shamira, Mushtaq Bhai.